You can start.
Okay, so just a little background. I did my training in Armenia and my plastic surgery training, and then I moved to United States. So, and I've done multiple years of research here, starting at Mass General Hospital at Harvard, and then continued in Cleveland Clinic. So before joining Mayo Clinic last year, I've done also microsurgery training in Cleveland Clinic and specializing on breast reconstruction and lymphedema treatment as well. And then my main practice here at Mayo Clinic is treatment of breast cancer patients, so breast reconstruction that can be like free flap or other surgeries, and also lymphedema surgeries, and also major reconstructions. So now for the lymphedema, right, I do not have any conflict of interest. So the lymphedema is a chronic progressive disease, and it can affect about like 10 to 20 million worldwide. And in Western societies, most common cause of lymphedema is cancer-related procedures such as lymph node dissections and radiation. And about 45 to 50% of women will get lymphedema following axillary lymph node dissection and radiation, while in lower extremities, this number is even higher, about up to like, based on different reports, it can be up to 70% of lymphedema following groin node dissections and pelvic node radiation. And this can present significant like financial burden. It's considered not curable, unfortunately, and it also like affects quality of life and of patients. So the goals for the treatment usually includes decreasing the patient morbidity, improve function, and improve the quality of life. As I mentioned, it is still widely considered not curable. However, I do want to mention that there are like more and more cases, reports where the cure have been reported. And by saying cure, I mean when the patient who previously had to use conservative management options such as compression dressings or stockings or manual lymphatic drainage or like pumps, that following the surgery, they were able to graduate all these treatments. So when I see the patient for the lymphedema, my initial consult, right, it starts with the physical examination. The classic clinical sign for lymphedema used to be Kaposi-Steamer sign, which meant like inability to pinch the foot, the skin of the foot, or so. And other physical examination criteria are circumferential difference between two upper extremities or two lower extremities if we are dealing with unilateral disease, and it used to be accepted that the difference more than 2 centimeters is diagnostic for lymphedema, or the volume differences, and the accepted volume difference was 200 cc. However, all these tape and volumetric measurements, they have poor specificity, they have poor sensitivity. There is a very high intra-rater error and very high inter-rater error. So they are not very reliable. So when based overall on the clinical picture, there are multiple clinical classifications for the lymphedema, and the most commonly accepted ones are CAMPESI clinical staging and all CAMPESI clinical staging or International Society of Lymphology staging, right? And if you follow any of these stages, it goes by the progression of the disease. So lymphedema is not a true fluid edema disease only. It starts as a fluid disease. However, more disease progresses, this constant presence of protein-rich lymphatic fluid within the tissue causes inflammation of tissue, fibrosis, and it also makes our body to accumulate fat in the affected extremities, so lipodystrophy as well. So slowly this fluid dominant disease gonna progress to mixed with fluid and solid components, and eventually it may become a solid component. And at the very advanced stages of the disease, then we can see skin hardening and varicose changes, and also tissue infections like recurrent cellulitis. So after physical examination, the next thing that becomes very important is evaluating the extent of the lymphatic injury. And for this purpose, we use indocyanine green lymphography. So with this indocyanine green lymphography, we can evaluate what we call dermal backflow patterns, and which allows us to understand what's the lymphatic injury, and also we can stage the disease and the severity of the disease. It provides us ability to do a real-time assessment, and also it allows us to come up with a surgical plan, and we can use this technology also during the surgery for mapping and confirming the patency of the anastomosis. So these are like different types of the devices. Basically, indocyanine green lymphography uses like near infrared laser to detect the fluorescence dye, that's the fluorescence that comes from the ICG, right? So the one is spectrum, the other one is SPI-FI. I currently use the SPI-FI. So this is just to understand the lymphatic structure of, as we can see, in the epidermis, we have the lymphatic capillaries, and within this dermal layer, we have the precollector vessels, and the lymphatic fluid can go in these vessels through like all the directions. But in general, okay, so then the fluid continues to go from the superficial layer to deeper layer, and in the subcutaneous tissue we have these major collecting vessels that carry the lymphatic fluid from the periphery to the central parts. So along the upper extremity it will go to the axillary lymph nodes, or along the lower extremity it will go to the groin lymph nodes. And we also have some collecting lymphatic vessels in the deep tissue. And these collecting vessels, they have valves inside them, like in veins. So the normal flow is unidirectional. So when there is a obstruction in one of the, at the level of the collecting vessels, as we can see, such there is like obstruction in the axillary axilla or in the groin. Once there is a pressure buildup in the collecting vessels, eventually these valves will fail, and the lymphatic fluid gonna change its direction of the flow. It's gonna go back from the collectors to the precollectors, and it will use this dermal network to drain the upper extremity. So And based on the extent of this, we can stage the severity of the disease. And indocyanine green lymphography allows us to see this picture. So this is from the left to the right. If we can see, the linear pattern is the normal pattern that we see on a healthy patient. Once we inject the dye, it gets picked up by the lymphatic system pretty quickly, and within few minutes you can see the lymphatic fluid reaching from the web spaces to the axilla. The rest of the patterns, such as splash, stardust, or diffuse, those are abnormal patterns indicating the severity of the obstruction within that lymphatic system and how much lymph fluid is flowing using the superficial network. And another thing, when we do the indocyanine lymphography, I always do like immediate scan, and I also do a delay scan. So in the left, you can see that when we do the immediate scan, the patient showed like a different picture of the lymphatic drainage pattern. And even on the left side, in the right extremity, there was just a linear pattern, right? However, after delayed scan, we can see that in the thigh, there is a new like a stardust pattern, and while in the left side, there is just like entirely stardust pattern. So this tells us that it takes time for this fluid to reach to the obstruction and show the final pattern, how the extremity drains the lymphatic fluid. So in order to see the severity of the disease, we need to do the delayed scanning. And based on the different patterns that we see, within the upper or lower extremity, this one is just like an example for upper extremity, we can stage the disease by this is arm dermal backflow pattern staging, by how many segments of upper or lower extremity is involved carries this, like shows the dermal backflow patterns. And based on this, then we're gonna decide what type of surgery we can do. I'm just gonna go through this quickly. So when for the surgical, in general, the treatment of lymphedema about like 10 or 20 years ago, it was considered to be the first line treatment used to be the conservative management that included complex decongestive therapy, which includes compression dressings, manual lymphatic drainage, pump, and like taking care of hygiene and all this kind of stuff. Now the surgical treatment is getting huge attraction as well. So I would say it goes along with the conservative management. One complements to another, and if you want to get the good results, we have to intervene very early. So I just need to move something on my screen. So this is the algorithm that I currently use in my practice for my lymphedema patients. So when I see them, the first is physical examination, right? And the physical examination gonna help me to determine if this patient is more fluid disease, or fluid dominant disease, or solid dominant disease. And next, I'm going to do the imaging indocyanine green lymphography to confirm the diagnosis and to stratify the disease severity, or like to stratify the lymphatic injury. And following that, based on if the patient is fluid predominant disease, then The signs include such as pitting edema, or there is a fluid excess in bioimpedance, and there is minimal lipodystrophy and fibrosis on MRI, then I'm gonna perform physiologic procedures that are aiming to remove the fluid. And these physiologic procedures include lymphovenous bypass or a vascularized lymph node or vascularized lymph vessel transfer. If the patient is on physical exam, there is a significant lipodystrophy and fibrosis on MRI, then I'm going to do some type of debulking procedure. And most commonly, it is a liposuction with immediate skin contouring. So let's talk about the lymphovenous bypass. And this is a classic sign of pitting edema and non-pitting edema, right? Like between both extremities have a lymphedema, but the left side is more severe because it's already a solid dominant disease. So as I mentioned, for the fluid predominant disease, we're going to use physiologic procedures that help to remove lymphatic fluid, and those procedures are lymphovenous bypass, or other name is lymphatic-venular anastomosis, and vascularized lymph node or vascularized lymph vessel transfer. So to perform a LVA, what we need, it is a less invasive procedure. It does not create like donor site morbidity. However, we need to have a good lymphatic vessels. We need to have a linear patterns on the ICG lymphography to perform good quality lymphovenous bypass. While in the case of lymph node transfer of lymph vessel transfer, these procedures do not depend on the quality of vessels at the recipient side. However, they are more invasive procedures. So the way that we think is when we do lymph node transfer to the affected area, these new lymph nodes or lymph vessels, they are able to make connections to to the recipient side, and then kind of directly suck the lymphatic fluid and drain it into the venous system. So lymphovenous bypass procedure is considered super microsurgical procedure, and we call it super microsurgery because the vessel size is very small. And in conventional microsurgery, we deal, if you're doing like a digital artery, that's like typically the smallest of vessels, right? For the replants, it's about 0.1 millimeter size vessels. How when we do deep surgeries for the breast reconstruction, these vessels are 2 to 3 millimeter vessels. However, for the lymphovenous bypass surgery, the lymphatic vessel is about 0.2 to 0.8 vessels, millimeter in size. So those are like different configurations of the anastomosis. On the left side, you can see this ruler. So there is a lymphatic vessel. The size of this lymphatic vessel is 0.25 millimeter. So this yellow background that you can see, guys, the small square is 1 millimeter. And we have here end-to-end anastomosis, end-to-side anastomosis. So with lymphatics to the vein, we have octopus anastomosis, when we intercept multiple lymphatic vessels into the vein, and we have end-to-side octopus, like different configurations. The main goal during when we decide what type of configuration we should use is to prevent venous backflow to the anastomosis. So we have to choose a vein that does not have a strong blood flow, and to prevent the venous reflux. Otherwise, that connection gonna clot and it's gonna fail. And the sutures that I typically use is 11 or 12 for sutures. So during the surgery, it's interesting that sometimes we can even see immediate decompression of the limb while on the table. So on the left side, we can see I performed.
I think the sounds also was caused by the hacking of our link.
Oh, okay.
Please try again.
Okay.
Yeah, we can see it well. You can continue.
All right. Okay. So here you can see like these green lines. I use the same indocyanine green lymphography to outline, to map my lymphatic vessels. And then I also use infrared vein finder to detect the superficial veins. And then I base my incisions I design my incisions in a way that I'm gonna have both lymphatic vessel and vein within my incision, so then I can have a positive result. And on the right side, I mean, if you even compare the circumferences like of these limbs just by visually, after like 6 hours of surgery, 7 hours, 6, 7 hours of surgery, there was significant decompression of this limb. So if you are making good quality connections, you can get amazing results. So this is another patient of mine. I think the patient came to me with a right lower extremity lymphedema. This is like status post prostatectomy and right inguinal lymphadenectomy and radiation therapy to pelvic to the pelvis and immunotherapy. And we did the indocyanine green lymphography. So on the immediate scan, we can see all these linear patterns, right, in both lower extremities. However, during the delayed scan, we can see that the right lower extremity that the patient was complaining from lymphedema already has this superficial stardust pattern covering the linear patterns. And we noticed that there is some dermal backflow pattern on the left side as well. So the patient has a signs of subclinical lymphedema on the left side as well. So it is very important to do bilateral examination, imaging, both for the comparison and also for to find the subclinical disease. So currently, I also do contrast-enhanced ultrasonography with my radiology colleagues here when they induced a special dye and use a ultrasound to detect the lymphatic vessels, and then they map it for me. So the difference is that one of the downsides of indocyanine green lymphography is the penetration depth. The penetration depth of the near infrared light is less than 2 centimeters. So any vessel deeper than any lymphatic vessel deeper than this, it's unable to detect. While the ultrasound is able to detect these vessels. Without conventional ultrasound is not going to work without any contrast because the size of the vessels are so small that it's not going to detect. There are some institutions that currently use ultra high frequency ultrasounds. These ones are able to detect the lymphatic vessels. However, with contrast enhanced ultrasound technique, we are able to use the regular like 15 megahertz probes to detect the lymphatic vessels. And also the superficial lymphatic congestion cannot obscure the lymphatic vessels in case of ultrasound. And the other thing, we can use this for the patients who have iodine hypersensitivity, because the indocyanine green is iodine-based contrast. This is just before the surgery. As you can see, we inject the dye, and I'm using my green marker. I've just followed the fluorescence to map the lymphatic vessels. And then I'm going to use the superficial vein for the mapping of the veins. So on the left picture is the same patient. We can see the mapping that was done using only ultrasound, contrast enhanced ultrasound. And on the right side, we already did on top of that the indocyanine green lymphography as well. And the idea is we are trying to detect as many lymphatic targets as possible. We also currently compare the outcomes between the indocyanine green lymphography and contrast enhanced ultrasound, as we are trying to see if it can just simply be a substitute of this technology for places that do not have ICG lymphography. So, and this is intraoperative picture. This is actually video. So this is a lymphatic vessel, and you can clearly see how it is actively draining this fluid, which is a lymphatic fluid. So those are the types of lymphatic vessels that we want to use during the lymphovenous bypass surgeries, because this type of lymphatic vessel actively drains lymphatic fluid, so the outcome gonna be more favorable. And here we performed end-to-end anastomosis, different anastomosis, and we immediately used the indocyanine green lymphography to confirm the patency. We can see how the fluorescent dye flows from the lymphatic vessel to the venous system. And I ended up doing about 6 incisions, and I created 9 lymphovenous anastomosis. So immediate post-op day 3, and then post-op 1 month results. So this patient has had about 30% of volume reduction, and also when the quality of life improvement was significant. So when I speak with the patient, he mentioned that it takes less time for him to manage his symptoms, that his right leg responds to the compression treatment better now, and is able to, and also the manual lymphatic drainage is more successful, and on a daily basis there is less heaviness of the lower extremity, and the skin does not feel as tight as it used to be. And again, this is another case of left lower extremity lymphedema, and this is status post radical hysterectomy and bilateral lymphadenectomy and radiation therapy. Again, the patient came complaining only from left lower extremity lymphedema, and the immediate and delayed scan with ICG showed that she has problems on the right side as well. On the proximal thigh, there is a stardust pattern. We performed lymphovenous bypass surgery, Again, this is the preoperative mapping. I performed like 6 incisions with 14 LVAs. And again, immediate, like she had about like 15% volume reduction, and patient was able to have a very active lifestyle. Like entire summer, she did not use any compression or anything. However, her swelling was better than like compared before the surgery, when she used to have all these compression stockings and like was minimal active, had the leg elevated almost like all the time. So this is another case of a 50-year-old female. So she, this patient had a, I'm sorry, breast cancer, followed by that was treated with bilateral radical mastectomies and left axillary node dissection. And following all these procedures, she developed the lymphedema. She has done 5 years of complex decongestive therapy, and however, the swelling progressively got worse. And during the clinical examination, there was no pitting edema. Swelling partially, there was pitting edema, swelling partially resolved with compression, and there was no significant lipodystrophy. And this is a case that I did with my mentor during my training at Cleveland Clinic. I worked with Dr. Vahe. He's one of my mentors, and the other mentor is Dr. Schwartz. So when we did the ICG lymphography, it showed stardust and diffuse pathologic patterns from distal forearm to the axilla. So we did not find any linear patterns. That's why we decided to perform a vascularized lymph node transfer, lymph vessel transfer actually. So those are the different types of the lymph nodes that we are able to use. And in my practice, I prefer either the thoracodorsal lymph nodes or the groin lymph nodes. However, as I mentioned, currently there is this new flap which is called vascularized lymph vessel transfer. So we are not harvesting any lymphatic nodes. However, we make sure that in order to do that, you have to stay above the superficial fascia, and when we do this, we harvest only the lymph vessels, and the data shows that they work pretty well, almost similar as the lymph node transfer cases. So in this case, we're going to use the skip flap for the upper extremity. We're going to excise this part, the skin and subcutaneous tissue from the left upper extremity. We are going to use the radial artery and veins for the anastomosis. I think we did antecide anastomosis, and we brought the skip flap. And one of the reasons that we don't like using the lymph nodes because they are very bulky. So here is the comparison of vascularized lymph node transfer to a vascularized lymph vessel transfer. Well, on the left side is the groin lymph node, right? And the right side is just the skip flap. So this is what we call like Rolex deformity. I mean, these patients already suffer from disfigurements sometimes because of the volume of the arm. So creating this type of deformity can be a challenge for the patient. That's why we initially a vascularized lymph vessel transfer procedure was done by Dr. Kashima. And now Dr. Wei Chen does advocates for these procedures, and as I mentioned, he's my mentor, and we had a pretty good result. So I prefer this procedure as well. And one of the important things is also when we evaluate these patients to understand truly which procedure we should do. So this is a patient who I operated, who like initially was seen by other physicians, and so this is on the left side is her preoperative before any lymphatic surgery images. So like you can see that she has a significant circumferential difference, and she had a bilateral mastectomy, left upper extremity, left axillary lymph node dissection, and radiation. Developed lymphedema and was presented for initial evaluation already about like having the disease for about 5 years or something. So after the evaluation, they recommended lymph node transfer for her, and they performed a omental lymph node transfer. There you can see the S-shaped scar, and in the case of omentum, because there is no skin component with the omental flap, it gets buried under the skin. So this is her about like 1 year post-operative pictures. Patient did not experience any positive outcome. There was no swelling reduction, no changes of like heaviness in the arm or anything. Her disease got even worse, and you could even feel this omental flap under her skin of the forearm. So this is a case clearly when the correct procedure was done on a wrong patient. The patient had a solid predominant disease, and when the patient is presenting with a solid predominant disease, lymph node transfer is not going to help, because the most of the disease is lipodystrophy. That's why she did not experience any positive outcomes. So, and here is her lymphoscintigraphy, where you can see all the significant dermal backflow pattern and significant volume circumferential differences when I saw her. So what I performed is the circumferential liposuction with immediate skin contouring. So for this patient, you can see what we call positive squirrel sign. The liposuction for lymphedema was initially done by Dr. Borson, who typically does not advocate for skin contouring, while Dr. Chan advocates for the skin contouring as well. So we perform very aggressive liposuction, and then once there is a positive squirrel sign, which means this excess skin is on a stretch is more than 5 centimeters, then we just go ahead and do the skin excision. So this is right after immediately after the surgery. This is 3 months post-operatively. I mean, there is a significant volume reduction. And once we convert this patient from this stage, late stage 2 disease to more like stage 1 disease, then we can go ahead and do other physiologic procedures to slow down the progression of the disease again, which can be either lymphovenous bypass or lymph node transfer surgery. And this is the paper comparing actually the lymphedema liposuction with immediate lymph contouring without to the patients who got the contouring, to the patients who did not get the contouring, and the outcomes in terms of like skin necrosis, wound adhesions are better with immediate skin contouring. So in general, if we conclude, so the lymphedema surgeries require a teamwork. So we need the patient to be compliant to all the conservative management. We need these. We need a lymphedema therapist who's gonna take care of them before and after surgery, and we need a surgeon. We need the toolbox such as ICG lymphography, the super microsurgical instruments, and appropriate training. The super microsurgery is not a microsurgery. So even if you are very comfortable with microsurgery, you need to do additional training to become comfortable with these extra small vessels. And early surgical intervention is important. So we can have the patient in a stage where they still have functional lymphatic vessels to perform one of the physiologic procedures. Otherwise, by the time they plateau with the conservative management, they are already have pretty extensive lymphatic injuries. So for some of them, lymphovenous bypass surgery is not an option anymore. So I think this is it, and I'm happy to answer any questions you might have.
Thank you, dear professor. It was very interesting and presentation with excited results. So it was one question from the audience. Is a question from Dr. Ilhom Niyazov from Tajikistan. The question was, what was the major cause of the lymphedema in your patients?
Major cost?
Yeah, mainly cause.
So I just want to understand the surgical costs you ask, or like the daily living cost, like what they.
Dr. Niyazov, could you explain your question? The cost.
The cost of the surgery. I mean, to be honest, in the United States, it's like insurance-driven system, right? I don't know how it's in Tajikistan, but back then when I was still in Armenia, we didn't have major like insurance system. Now I know that there is some type of insurance, but it can be quite expensive here if you don't have insurance. Because like any other free flap surgeries, it can be like above $100,000 or something. It depends.
And I also had some questions. The first one is, how many cases per year do you perform in your practice? In your
for the lymphedema particularly, probably 20, 30. I mean, it depends. I kind of try to have at least 3-4 lymphedema patients in a month. As I mentioned, those are like almost all day surgeries, and I also do breast reconstruction patients, and also other major surgeries, gender formation. I do have gender formation practice as well. So based on these patient populations, it's like kind of on the surgical days, probably about 20 to 30.
And do you use immediate lymphatic bypass after mastectomy, for example?
Yes, that's another thing that we do, immediate lymphatic reconstruction, and data shows that at least for the upper extremity, it can reduce the lymphedema rate from 6 to 20%. I mean, based on different reports. So we do offer immediate lymphatic reconstruction. And for that reason, once my breast surgeon is done with the axillary lymph node dissection, we typically do arm reverse mapping. So with it can be either methylene blue or it can be isosulfan blue, right? And also we find the lymphatic vessels from the upper extremity. Typically, I try to perform at least connect at least 2 or 3 lymphatic vessels when I do the immediate lymphatic reconstruction. And then I will also do immediately indocyanine green lymphography to document the baseline of that patient's lymphatic drainage and confirm the patency. And we'll follow up them on a 6-month basis with doing also indocyanine green lymphography to detect any signs of lymphatic injuries.
And do you use the bypasses routinely or after the evaluation of the risk factors of the patients? I mean, do you use it each time?
Yes,
Yes.
it's if the patient is gonna go to for sure for axillary lymph node dissection, it's confirmed, then I'm sorry, then we will offer the procedure.
And what is the percentage of bypass inefficiency? Because sometimes the collateral cannot be work in your practice. Do you have the data?
No, I mean, I don't have that data yet, but I know from so you mean how much it works, right? That's, yeah. So in general, I had the patients that I'm already following up for a year, and as I mentioned, I do with indocyanine green lymphography, and I don't see any dermal backflow patterns. And I have some patients who we detected that some dermal backflows already in a forearm, and I recommended early intervention. So even though my own practice numbers are smaller to make any conclusions, but I would say in my practice I have seen at least reduction in my population, reduction of that risk to 10%.
Oh, good results. And do you use the rehabilitation after that kind of surgery?
Yeah, I mean, yes, of course. The rehabilitation is I recommend compression dressings for at least a month for these patients, and if it's just immediate lymphatic reconstruction, then if they don't have any swelling or anything, I don't recommend them continuous wearing of compression stockings, but we do bring them on 3 months, 6 months. We rather follow them to make sure that we don't miss any early signs of lymphedema. And for the therapeutic lymphovenous bypass surgeries, the protocol is the same. I recommend 1 month compression dressings, and then they go back to their compression stockings, whatever they used to wear before the surgery. And after 6 months, once we kind of know that the results of the surgery should be already significant, we tried to see if the patient can tolerate to kind of reduce the amount of conservative managements that they do.
And also there is some question from the chat. So do you recommend the surgical reconstruction in all cases of lymphedema, even in first and second stage of lymphedema?
Yes. So the first stage of the lymphedema is the critical stage that you can do successful lymphovenous bypass, because this is the stage when the patients have a fluid predominant disease, and which may partially resolve by head elevation of the upper extremity, which means they have functioning lymphatic vessels. So those are the lymphatic vessels that you want to target during the lymphovenous bypass surgeries. And in the second stage is already the patients are getting less, the disease is more advanced, so it's more like mixed disease. And when you look for the second stage of like ISL classification, this is such a wide range of patients, which can be from fluid predominant up to like solid predominant disease. Again, you have to look, they definitely are qualified for the surgery, but the type of the surgery might be different based on what's the stage of the disease and based on lymphatic injury. I do recommend early surgical intervention, because the data shows that, I mean, we do know it's a chronic progressive disease. So if the patient has the lymphedema, it's going to progress slowly. When with a only rehabilitation, which means the conservative management, such as manual lymphatic drainage, or like aerobic exercises, or compression pumps, or like compression dressings, right? We don't change anything in the pathophysiology of the disease. We just help physically to push the fluid using that superficial, dermal network, to the parts of the body that is has normal lymphatic vessels, so they can carry, they can like take it away, right? With the surgery, when we do the lymph node transfer, or when we do lymphovenous bypass surgery, right, we change the pathophysiology. We provide a new ways of removing the fluid. So this is very important to do early intervention, and otherwise, so the patient has a chance to kind of get a cure. As I mentioned, we consider it the disease not curable. However, there are cases with early intervention that patients were able to downgrade all the compression devices or anything that they used to use.
I think it was the second part of your answer was the answer to the next next question. So it was another question. So I heard that the rehabilitation plays more important role than the anastomosis. Your opinion? So you told about it.
It is, and one thing I want to mention, like rehabilitation is very important. When I see my patients, I tell them that you have to be compliant to your rehabilitation. You have to do like all the conservative managements that you used to do before. The surgery is not going to magically cure you. The goal of the surgery is not only, there are multiple goals of the surgery, as I like improve the quality of life, decrease the number of frequency of infections, and all these things are considered like positive impacts. Decrease the volume. So, but in order to the lymphovenous bypass to be successful, they still need to do their conservative management, conservative therapies.
Oh, thank you. So there is no questions from the audience. So thank you so much for your interesting presentation. I think you can join next time, and maybe you can come offline. You are welcome anytime here.
Thank you so much for the invitation. Yeah, of course, we'll stay in touch. And as I mentioned, we can talk in the future if there is like some patient population, and we can think about like maybe doing some surgeries. I'm happy to visit and happy to help. Let's stay in touch. Okay, and thanks for the invite.
Okay, see you next time.
You take care.
Bye. Okay, see you.